All right. Okay. So to start with now, we are looking at the relationship that we have and Hamad. What is still now? Even now? Thank you. Okay. So now we are going to be looking at what is the relationship between us, that is the private nursing service, and Hamad. And what we are supposed to do as nurses, what are our rules, our regulations, and other things that will follow. Number one, what would be the objective of this class? The objective of this class will be looking at one, understanding the partnership between NESCO and PNS and the goals of our outsourcing company. Number two, understanding the scope of service and practices as PNS nurses. And number three, enumerating the rules of a nurse in a home care setting with alignment to PNS requirement. Number one, Hamad, where did you go for your medicals? Where did you go for medicals? One of the health centers for Hamad. Where did you go for ILS? You have not yet gone for ILS. So you probably go to ILS at Hamad. So Hamad Medical Corporation is like the government hospital or the main government hospital that we have here in Qatar. And PNS is part of these services, or the home health care office is part of Hamad. And what do they do there? When they have admitted one of the patients or patients in Hamad, and this patient has to have a long stay in the hospital, they cannot just keep keeping the patient because that bed is booked with a number of people all around up. And for them to be able to receive all the emergency cases and for them to be able to treat those emergency cases as well as these other chronic conditions, they decided to go to the patient's house, take a room, and create a small hospital room for that patient. And because they have created a small hospital room for that patient, they now need a nurse to go there and be taking care of that patient with the same services that you would have rendered in the clinic. So while others are going in clinic, like they are going in the hospital, you will be going to the patient's home. And the site for which you will be going to the patient's home is what they call the PNS, the Private Nursing Service, under continuous care for Hamad. Is that understood? And that is where you and I come. We now come to complete. We now come to go home and take care of those patients, though not in the hospital, they are still having the same hospital environment. When you enter the patient's home, it is the same as you see your stimulation room. We have the hospital bed, we have all hospital equipment. The whole environment is a small private room of a hospital. And this is where you will go and you will practice with collaboration with myself, with the case manager, with the patient's doctor, with the PML or the home office itself, hoping that we are able to give this patient the same amount of care, the same quality of care as though they were in the hospital. Is that understood? Okay, what is our goal? Our goal is to give a safe and high quality care to the patient. Next, we have NESCO for home health care. We are one of the outsourcing agencies. We are not the only outsourcing agencies. There are about 20 outsourcing agencies for PNS. 20. So the competition is high. Everybody wants to bring in the best nurses, highest quality, everything that you can offer. So there is no chance for us to play around. There is no chance for us to be slack or be lazy. There is no chance for us to behave anyhow, because immediately they realize that you are not taking care of your patient the way you're supposed to care for that patient. The family has every right to go back to PNS and tell them, I do not want this nurse. She is not good enough. She is not skilled enough. She is not conscious enough of the patient that has been given to her to care for. And if PNS, after investigating, approve the fact that you are not a competent nurse, they will take that patient from us and they will give another outsourcing agency. Is that understood? And that is the reason why when you are given the second warning letter, portion of your salary will be deducted as penalty for the crimes that you committed. Because whatever you must have done that will prompt that second warning letter is capable of you losing that patient. And if you lose that patient, that means the company has lost the patient. And that means our credibility is reducing. And if our credibility is reducing, other nurses will come and they will not have a patient because we have given a bad reputation for ourselves. Is that understood? Okay. Now, providing quality care, 1, comprehensive educational training, 2, assessing and evaluating, and 3, the 5 core competency. And because of the quality of care that they are expecting us to offer, that is why you need to go through all this. It is the reason why you have a month of training in class before you are given a patient. Because we do not want you to have any lacking. You are nurses with several years of experience. But are those several years of experience tailored to the practices that we have in Hamad? No. And because of that, you will have to go through their own policies and their own care that is tailored to their patients, according to their rules and their regulations. Next, service agreement. We have spoken about the service agreement already, so I'm not going to go about it again. However, the requirements for you to be able to work as a PNS nurse, number 1, I ask you guys to give me your updated CV. I send you a format for a CV to fill, right? When you fill that CV and send to me, I have not even compiled your documents, so don't delete them from my inbox, okay? Now, I will have to compile your CV and your documents one after the other. Next, your QID. Your QIDs are not out yet, right? Your QID is out. Okay. Next, we have your license. It is in your responsibilities to make sure that your license are valid at all times. If your license expires today, I will withhold your services. Do we understand each other? It means on no occasion or the other should your license expire without you informing me 3 months prior to the time your license will expire. So when you realize that your licenses will get expired in August, you should tell me now that in August my license will expire, and I will start making arrangements for you to get your license renewed. When you have a temporary license, it will take you 6 months for you to have a permanent license. You should inform me when it is left 3 months for that license to be renewed. Because there are requirements that you will need to submit to the Ministry of Public Health to be able to get that license renewed. And it needs me to tell you in time to start getting those documents ready so that we get that license renewed in time. If you forget, that is why I tell you, it is not my responsibility to remind you. It is in your responsibility to tell me that your license is about to get finished. Are we communicating? Now, after you have gotten your permanent license, they are giving you a 80 credit points to study, to be able to renew the license in the next 2 years. That means you have 2 years, which is 24 months, to study for those credit points to be able to get your license renewed. Please and please again. You will be having notifications in your emails indicating that there is a session. Those sessions are offered by the Ministry of Public Health. And they will tell you this day, this month, we are having this session for this particular thing. Maybe say infection control. Maybe say medication administration. Maybe say communication or assessment or whatever, mental health, dementia, Parkinson's. Please take minutes, study. They will give you before and after assessment, and you listen to what they say and you finish. When you finish, they will give you points for that session that you have attended. And when they give you the points, upload the certificate on the website. Gradually, within 2 years, you will complete the 80 points. And when you complete the 80 points, 3 months before your license expires, you should inform me that your license is about to expire within 3 months. I will check your points to make sure that you have all 80 points. If you have all your 80 points already valid, they will initiate the renewal of your license. And within that time, before the day that your license is supposed to expire, we will have the new license and you will continue working. A second that your license expires under PNS, you cannot work. Do we understand each other? Okay. Next, community service. The delivery of care in a home care setting. 1. Patients from different ages and case varies. Just like in the hospital, they will tell you that patient's care is individualized. You can never go into a ward and generalize all the patients. You cannot say that because I am taking care of 10 malaria patients, all the patients have the same conditions and the same signs and symptoms. No, you must take care of an individual for who they are, holistically, looking into considerations, their needs, their worries, their pain, and solving one after the other. Is that understood? So because you are going to be the only nurse and to be given to just one patient, I do not see any reason why you should not do your job perfectly. Next, post-discharge from confinement, follow-up, long-term care, neonatal, infant, toddler, and elderly. What are they talking about? Most often we will take our patient from the hospital. Okay, so when they have made arrangement of when this patient will be discharged, they will inform us that we have to give a nurse, or let me start from here. When you have passed competency, I will submit your document that we have an available nurse for utilization. Now, they will check for the number of patients that has been referred to PNS from the in-service. And when they see those patients, if your own patient is still in the hospital, they will call us and ask us to send you to the hospital. You will go to the in-service and you will work in the hospital for 3 days. So that first, you'll be working with a case manager for that patient. You'll be working with a nurse that has been taking care or in charge of that patient. And you will have handover care from the in-service to the home care. Is that okay? They will tell you what the patient needs, what the patient has to be done, when it has to be done, for what reason these particular activities has to be done. Do we understand each other? And after you have taken all those information for 3 days, you will come out now getting all the medication files. You will come back. I will compile the files and compile your PMIs, and you will go to the patient's home. Is that understood? Okay. And this is what they talk about post-confinement hospitalization. When you are leaving from the hospital, you should be living with your follow-up care or your long-term care. When is the next appointment? When is the next hospital visit? Who is going to come home to care for that patient? You know the patient's doctor. When is the patient doctor coming home? Or when are you going back to the hospital with that patient? Are we together? Next, nurse roster. I have already spoken about nurse roster, so I will not talk about it again. However, you have the roster given to you. That is what your roster looks like. This roster is the same for those that are in the hospital, for the nurses that are working inside the hospital, and for the nurses that are working for home health care. So when you finish your roster, I will always send the rosters by the 26th and the 27th, or from the 25th, so that it can make 2 or 3 days with you, just because you will need to have the decision maker to sign. The decision maker of the family will sign, will write their cure ID, and they will give a comment about you. And when they sign and make their comment, you will send me back the roster. I will combine it with other documents and the agreement for that patient, and we will send it back to PNS every month. Is that understood? Okay, I will not talk about the reliever service because I have done so. I will equally not talk about this because I have. Next, we have team visits. Now, when you are home, we will always visit you. I will visit you alone if it is needed. Mostly when I am going to hand over a patient to you, I will come alongside with Madam Patricia, who is the head of nurse education. And we will do our assessment, and we'll do the home risk assessment together with you. And then we will come back and prepare to go for you to start duty the next day. Is that understood? So when we go for the home risk assessment and we do our initial assessment and we realize that the home is safe for you and for the patient, the next day you will start duty. And I will compile all the other documents and send to PNS indicating what the patient has said, when they want their duty to start and when they want it to end, and every other information that follows. Okay? And because of that, for your first visit, I will visit you for the first 5 days that you start duty. Now, I might visit you with the infection control, who is Madam Tina, or I might visit you with the quality, who is Ma'am Aria. Is that understood? And here we are going to be evaluating how you are filling your PMI forms, if you are respecting every rules for filling your PMI forms, and how you are carrying on your duty, and if you are respecting every policy for which you are supposed to be guarded for that patient. Okay, now we have a home visit is a professional service, and a professional service conducted in a patient's home to provide care, assess health needs, and ensure the quality and safety of care delivered by the nurse to the patient. Number 2, it involves a planned interaction between healthcare providers and the patient or family, focusing on maintaining optimal care standards and addressing specific goals. Most often we will come for home care, you will not know. I will just tell you that I'm at the door open. Sometimes before I come for the home care, I will inform you. It is the same as sometimes when PNS is going to visit you, they will not tell me. So I will not know and you will not know. And sometimes before PNS goes for visit, they will inform me as well as I will inform you. Is that okay? So at all moments, you be in your best behavior. Are we together? Okay. Next. Frequency of home visits. As I said, initially, I will visit for home risk assessment with you and with the head of nurse education. And then, within the first 5 days, I will visit you with the infection control or with the quality. After that period, I will visit you again after 1 month. That will be the day I will be bringing your rosters. Now, from that 1 month period henceforth, I will now only visit 25% of the total nurses population that are on home visits or that are for home care. Is that understood? So after I have visited you for the first time, and then at the end of the month, I will now only visit the total population for the nurses that are for home care, 25% only. It means if there are 300 nurses for home care, I will visit 25% of those total 300 nurses per month. If there are 500 nurses for home care, I will visit only 25% for the total population per month. So I will approximately visit you once after every 3 months. Is that understood? However, I might visit you once or twice in 1 week, depending on the situation. If there is an incident, if there is an investigation, if there is something that is wrong with that home, and if the patient makes a complaint, then I must come to investigate and see what is going on at home. Is that understood? Next, however, the nurse supervisor could visit, yes. I could visit you particular months for more occasions depending on what conflicts or complaints. That way I will have to come to do my investigation. Next, the purpose for the visit. When most often when we say we are coming for visit, the nurse starts trembling. We are not coming for visit to curse you out. We are not coming for visit to say, oh, you did not do this thing correctly, you should be doing it like this. We are not coming for the visit to make your life difficult. We are simply coming for visit to assess how you have been caring for your patient, to look at where they are lacks. If I realize that you have lacks with your documentation or with the quality of care you offer to the patient, I will indicate for the quality to have a class, an online class with you. If I realize that you are having problems with infection control in making sure that you keep up with your infection control documents or you keep up with managing your hand hygiene and every other thing, I will request for the infection control to give you a class. If I realize that you are having general problem with assessing your patient, with communicating, I will ask the head of nurse education to give you a class. Is that understood? And if there is a problem with your PPIs, with something you do not understand about it, when I get there, you should make up a query and I will re-explain to you how to fill it and we'll move on from there. Is that okay? So whether I am coming for home visit or other management or the doctor for that patient or the case manager for that patient is coming for home visit, I want you to be completely okay with that. Because if you have been doing the right thing from the get-go, you will not have any problem if I tell you I'm already outside. Is that true? Okay. Now, we have number one, the nurse supervisor. What is the purpose of the nurse supervisor for coming for home visit? We have to monitor the quality of nursing care provided to the patient. 2, to evaluate the staff performance and address any operational issues. 3, to provide mentorship and resolve issues. That is why I said I will always come if there is any problem or complaint from your side or from the side of the family. Next, to ensure compliance with care plan and patient's safety measures. You must have a care plan at all times. I should not come and I meet your communication board looking like this whiteboard. Because if you don't have a care plan, then you're actually not caring for your patient. Is that understood? Okay. Apart from myself, the nurse educator, what will she be coming to do when she comes for her own home visit? It will be to conduct skill assessment and hand-on training. They will be assessing your knowledge on physical assessment and general assessment. She will be assessing your knowledge on communication. She will be assessing your knowledge on medication management and administration. She will be assessing your knowledge on pain assessment, management, and reassessment. And if she realizes that there is something you do not know, she is going to do what? On hand-on training. She will do it there so that you can see it and implement when she is not there. Is that understood? Next, she is going to identify and address a knowledge gap. If there is something that you are not knowledgeable enough, with her questioning and her assessment, she is going to drill you through and make sure that that gap can be filled. From there, we are looking at quality. What will the quality coordinator comes to do during her home visit? Number one, she is going to assess the quality if care delivered and adherence to standards. If we talk about care for a wound, are you following all the standards to care for that wound? If we are talking about the tracheostomy, are you following the policy to care for a tracheostomy? If we are talking about insulin, are you following the policies and the guidelines to be able to administer and manage a patient with insulin? Do you understand? Next, identify areas for improvement in the patient's satisfaction and service delivered. So she is not only going to be assessing your knowledge and your compliance with policies, she is equally going to make sure that the patient is completely satisfied with the services that you are offering. Is the work that you are doing okay? Is the patient happy with the fact that you are their nurse? Because there will be patients that will be looking at ways to just throw you through the window. And when she comes, she will be able to get that information. If you've been sleeping on duty, or if you've been on your phone day in, day out, they will be able to tell that you have not been the best of companion, the best of nurse, the best of friend, the best of carer, or the best of whoever the person decides to represent you to. Is that okay? Okay, now we look at organizational adherence to organizational policies, which I have already indicated. Next, it will be the infection control officer. What will be the infection control officer's duty when she comes for home visits? Number one is to evaluate adherence to infection control policies, hand hygiene. How many times are we supposed to do hand hygiene? When are we supposed to do hand hygiene? How are we supposed to do hand hygiene? Until she is able to get all these answers and get a satisfactory answer from you, then you will need to still go in for more training or hand-on training. Next, educate the staff and caregivers on infection control. As much as we do not want to increase the patient's condition, we don't want to be the source of pathogen transmission. Is that understood? General objective of home visits. Rate, Molly. Number one.
Ensure patient care is aligned with organization and regulatory standards.
So good. Number two.
Provide guidance, support, and training for
Okay, number 3.
promote patient safety,
Mm-hmm.
quality care,
Mm-hmm.
infection prevention in the home environment.
Okay, number 4.
Address any challenges faced by the staff or caregivers to improve outcomes.
Okay, number 5.
Home visits are an essential component of a robust home care program, fostering a collaboration approach to care delivery and ensuring patient well-being.
Okay. So has that approved, has that conclude, or has this helped you to get a breakdown of all why there will be a home visit? Of why the doctor will come 2, 3 times a week if your patient is in a very critical condition. Because as much as they will be doing rounds in the hospital, they will need to do rounds for the very critical patients at home. And they will make that visit 2 or 3 times. You need to be compliant, you need to be welcoming, you need to be nice, you need to be receiving because there will be input and output. What they don't want you to do, they will remove, and what they want you to do, they will instigate, and then you will take it from there. Is that okay? Any question about the home visit? Any question? Is it understood? Okay. Let's go to the scope of practice. Read, Molly, Shamsa.
5 intrinsic to the role: professional and ethical practice, clinical practice, leadership and management, education, learning and development, research and improvement. Nursing care is provided through systematic SOAP
Copy.
ethical approaches requiring specialized knowledge, judgment, and skill derived from the biological, physical, behavioral, social, and oral nursing sciences.
Now, these are all the domains that you need to have. These are all the skills that we need you to incorporate. You have to have professional and ethical practice. Your professional and ethical practices as nurses should be top notch. You have to have clinical practice, and that is why before you are able to get here, you must have at least 3 years of clinical practice. Number 3, leadership and management. You must be able to lead because you will be going home and you will have care partners who probably are nursing assistants or caregivers, and we are expecting you to be able to lead the right way and not be bossy. Is that understood? Next, we are looking at educational learning and development. You should be able to educate the family. You should be able to practically show the nurse, the care partner, what to do, how to do, and the both of you plus the family and the patient should be able to grow within that health or within that patient state. If this patient came to you, or if you were given to this patient with bed sores, I should see that after 2 weeks, after 1 month, those bed sores are either completely healing, or are either completely healed, or are healing. Is that understood? Okay. Research improvement. Do not be those nurses of the 80s. Do not say as it was in the beginning is now and it forever shall be. No. You should be able to learn something new that can help you to take care of your patient. You should be able to receive new information and remove the old one if it does not align with each other. Is that understood? Okay. And for the next, we have the systematic SOP. What is SOP? What does SOP stand for? Anyone? What do you use to draw your nursing care plan? What does SOP stand for? Try. Clap for yourselves. Clap like you mean it. Of course, this is SOPI. Okay? SOPI is a tool in which we use in coming out with a perfect care plan for our patient. We have the subjective data, we have the objective data, we have the assessment, we have the planning, the interventions, and the evaluations. And if you are given a case scenario, you should use SOPI to be able to manage your case scenario effectively. Because subjective and objective data will be given to you in that case study. But what they are expecting you to do is assessment, planning, interventions, and evaluations. Most often, we start with our assessment, we don't intervene, and we don't evaluate. Or we start with assessment without completing, and then we go to intervene, and we don't evaluate. If you do not evaluate your patient and reassess your patient to confirm if the interventions you gave were good enough, you better not do anything. Because you might have just given a medication that is going to kill that patient. So it is better you allow the patient without intervening at all than to intervene without evaluating and reassessing to be sure that whatever you have done has helped the patient. Is that understood? So if you have been given a case scenario, if you have been given a patient, each time you are done with your interventions and you are assessing and making sure, evaluating, and the patient is okay, go back and do again head to toe reassessment, ABCs, and make sure that your patient is completely fine. In that way, you have done something. Because it is at the level of you reassessing that you are going to realize that your medication was not effective, it was effective, and there is need to call for an emergency. Is that understood? Okay. All right. So this is our full meaning for SOPI. And here we are having SOPI chart. SOPI is objective, that is the chief complaint or other information that the patient tells you. The patient tells you, I have headache, I have pain in the back, I have rashes in my buttocks, my breast hurts, my head aches. Anything that the patient tells you is a subjective data. Now, when you take the subjective data, what do you do with it? You use the subjective data to get number 2, which is the objective data. The patient tells you, I have pain. That is a subjective data. You take that information, you now use the pain scale to evaluate the patient's pain. This is you now saying, okay, my patient has pain. Mama, from number 1 to 10, what is the level of your pain? She says, my pain is 8. You have turned a subjective data into an objective data. Because now you can scale the pain, and 2 or 3 health personnel can confirm if they have to do that pain scale again. Is that understood? Okay. And when we have done our objective data, which is the vitals, those things that you can actually check. You checked the BP, and the BP was high or low. It is objective because everybody can see and evaluate. You checked on the glycoscoma scale. When you scale it out, it is now an objective. The symptoms or the subjective data was given to you is the patient says, I feel dizzy. I feel like I'll collapse. I feel like I'm losing my consciousness. When you put all that now on a scale, for the glycoscoma scale, you will now have a subjective, an objective data. Is that understood? When we leave the objective data, we are now doing our assessment. We are assessing the consciousness of the patient. We are assessing the problems. We are coming out with the nursing diagnosis. We are doing all these things. Assessment, it is either you're using your ABCs you are using your head to toe assessment, you are doing physical assessment depending on where you are. When you are done with your total assessment, it will help you to plan. What am I going to do? From where will I start? Your planning, if you were having, maybe say a patient with difficulties in breathing, you're having a patient who is bleeding, you're having a patient who has pain, from where will I start? Am I going to intervene by starting with the ABCs, or am I going to intervene by stopping the blood flow? You are now going to decide what you are going to do to be able to intervene. And when you have planned and come out with a good planning, you are going to have a good intervention. That is why most of the people start their assessment, go for competency. Immediately you have a wrong planning, you will start from a wrong place. And when you start from a wrong place, you start getting your assessor angry. Because of course, if I tell you that your patient is losing consciousness, is having difficulties in breathing, is having leg pain, and then you go, you are looking at the leg. Habibi, what is wrong with the leg? Like, are you telling me that the patient should die while you are looking at the pain on the leg? So until you are able to plan, and plan well as a nurse, your interventions will be wrong. Even though you intervene, but probably you kill the patient. Do we understand each other? So when you take any case scenario, you should be able to come out with a good planning. And that good planning, you should be thinking of first, you start with your ABCs. What is it that you have to start with? If the A has nothing, if the airway is patterned and no problem, if the breathing is okay, circulation is okay, then what is the problem? Pain. You go and do your pain. Are we together? I am not saying that when you get a scenario, you start behaving like a robot. No. For every case, there is that presenting signs and symptoms. The patient screamed and tell you, I have pain on my back. Will you go and start assessing ABCs? It was the patient that screamed, right? It was the patient that called for you, right? So why will you be assessing for consciousness? The patient is conscious. So you go to the pain. Now, at that moment, the pain is the primary focus for you. Because that is what is the problem. That is the only problem the patient has at that moment. So first off, you must know the presenting signs and symptoms, the factor, that thing that made the patient come to the hospital. That thing that made the patient start shouting is what we are looking for. If we do not see what is making that patient cry, if we do not see what is making that patient to have a problem, we do not know what to solve. Are there patients in your home country that are having hypertension and diabetes and at their home and doing their business and no problem? Of course. So secondly, the patient is not going to come to the hospital, you say it's because the patient is having hypertension. If that is not the primary reason why the patient is in the hospital. If the patient is coming to the hospital because of hyperglycemia, it is the hyperglycemia that brought the patient to the hospital. Is that understood? So we have to start looking at the presenting factor, the presenting signs and symptoms. When we have seen the presenting signs and symptoms, we assess and do our planning, and this planning should be able to tell you what? The patient's problem, including long-term and short-term actions. What you must do immediately. You are trying to carry the patient from bed to the wheelchair, and the patient starts losing consciousness. What will you do? Will you put the patient in the wheelchair? You take the patient back to bed, right? The immediate action is to take the patient back to bed and make sure that the patient is comfortable. And then you now start to do what? To assess what the problem is. If the patient at that moment starts having difficulties in breathing, then you go for oxygen. And then you start assessing what the problem is. Are we together? Okay. And after our interventions, we will now evaluate. We will have as many case scenarios as possible as the classes are going on and as we are going for community, for shadow, and after shadow we have even much more scenarios to solve before our competency days. Next, expectations from NESCO. We will give up-to-date knowledge, skills, implementations, policies, procedures, and compliant monitoring sheets for which you will need to adhere to each one of them. We've already talked about our 5 core competency. We've spoken about our SOP. You want me to give you a case scenario to solve? Okay, now you can take the case scenario. A 25-year-old female, right? A 25-year-old female presents to the hospital with complaint of acute abdominal pain. A 25-year-old female presents to the hospital with a complaint of acute abdominal pain, which she rated it as 9 on 10. She rated it on a pain scale as 9 on 10. The pain started 2 hours ago. The pain started 2 hours ago and is localized in the right lower quadrant. And is localized in the right lower quadrant. She reports nausea and vomiting. She reports nausea and vomiting. Now, with your first disease condition that you'll be submitting tomorrow, apply SOP to this patient and come out with the care plan. Is that okay? All right. We will move ahead. Now, the nursing rule in home health care setting. We have the nurse make a difference in all healthcare settings, but our rule is especially valued in the home health care setting. No matter what you think, no matter what you say, whether you are in the in-clinic or you are for home health care, a nurse should have their only tool, and that tool is the care plan. Without your care plan for each day, what are you doing? Because as you get in the morning, you have to assess your patient. And your assessment will be subjective, objective, and we have the physical assessment. From the physical assessment, you will gather from that patient that day, especially when you take off and you're coming back, you are rediscovering because you have not been there for a space of 24 hours. Now you go to the diagnosis. What have you diagnosed? What are you looking at? Is the wound you left or the bed sore you left the previous day worsened or is it healing? Is the patient looking, the skin sugar, is it looking okay or the patient looks dehydrated? Is the eyes of the patient looking colored or the patient is looking malnourished or suffering from anemia? Is the whatever, after assessing, you take your vitals, are your vitals okay? Maybe you left the patient with a normal blood pressure and a normal blood glucose level, Now you're coming, the blood pressure and the blood glucose is all over the roof, indicating that for the 2 days you went, the patient, for the 1 day you left, the patient never took medication. Are we communicating? Okay. Now from your diagnosis, you come out with your plan based on the assessment that you have done. Now, because of your assessment, you realize that the bed sores are worsened, or the diabetic foot is now smelling and every other thing is bad. You would plan where I will start from. You realize that the tracheostomy is looking reddish or is looking like it's beginning to infect. There are rashes everywhere. Then you know how to start, where to start from. I should be looking at you starting from the most to the least. And then we talk about our interventions. What were your interventions? What did you do as the nurse? We want to see what you did. You did wound dressing. You gave the patients medications and you managed after the medication was administered. You make sure that for that day you gave the patient 3 liters of water. You check the input and the output. Yesterday they recorded that the patient had 2 diapers changed, which were just scanty, but now you have changed 4 full diapers. Okay? Let me see your interventions coming with a solution to the problem that you are talking about. And during your evaluation, it is either correcting what you initially assessed, or your evaluation should come to tell us whether it is now getting worse. And if it is getting worse, do you want to reassess and start another line of treatment? Are we communicating? Okay. Any question on the care plan? Anything you do not understand? Okay. All right. Now we are looking at the rules for nurses in home care. 1. A home health care setting. Nurses play a vital role in providing personalized, patient-centered care. Their responsibilities goes beyond medical care, and including emotional support, education, coordination with other healthcare professionals. Here are what we are talking about. Number 1, for the clinical care that you will have to offer to your patient, we will look at 1, assessment. We conduct regular health assessment, including vital signs, wound evaluation. We are equally going to do what? Monitoring of chronic conditions and patients' progress. That is one of the duties and responsibilities you will be doing as a home care nurse. Number 2, medication administration. We will administer only prescribed medication. If the medication is not found on your medication list, you do not administer it. Are we communicating? And if you must verify, if they will come back and they tell you, or the family comes and tell you this medication has been given, administer. Call me and tell me you have been given a medication that is not on your medication list, and I will take it from there. Do we understand each other? Never administer any medication that is not medications that we send to you to go and take care of that patient. Next, wound care. Provide dressing and monitoring, wound healing, disease management, assess in managing chronic illness like diabetes, hypertension, COPD. Number 4, F, rehabilitation support. Support patients with physical therapy, exercise, and post-surgical recovery. Are we together? Care coordination. Communication with health team using ISBA. We've already spoken about ISBA, we've spoken about referral, and we've spoken about care planning, which has to be updated for each day, depending on the disease condition of that patient. Is that okay? Are you done? Okay. We have next patient and family education. It is in your responsibility to educate the patient on what their disease condition is all about and what it entails. Number two, to educate the family, especially if it has to do with lifestyle, mental health, and dieting. You will need to make sure that the cook, the care partner, the family is in the same accord with you to help you give the best care for your patient when it comes to nutrition and when it comes to their lifestyle. Because if you do not include the family into your care, how are you going to expect them to give fruit when they came with sweets? How are you going to expect them to give vegetables when what they have is sugar? Are you understanding? So you need to incorporate every other person that you need them to work in one way or the other to take care of that patient. Next, caregiver support. A trained family member, one individual. There will always be one individual that will request from the family to assist you. It is either going to be a care partner who is a nurse assistant or a caregiver or one of the family members of that family. So we are expecting that you and that individual should manage and be able to support this patient with medication, with hygiene, and mobility support. Is that okay? Next, lifestyle modification. Providing guidance on diet, exercise, and lifestyle changes to improve patient's health. If your patient is obese and you need the patient to kind of slim down or even lose 1 kg, then you must be able to educate the patient and the family. If your patient is depressed, you must be able to know what to do. If your patient suffers from dementia or Parkinson's, you must be able to know your role as a nurse to helping that patient and the family have a little bit of peace. Is that understood? Next, emotional and psychological support. You must be an advocate for that patient and their family to be able to provide them with emotional, with physical, with psychological support. Where first, you are the patient's advocate. It means you are there for the patient's good. You are the one to stand and to protect and to protest. You are protecting the patient and protesting against anything that is there to harm that patient. And number two, you are a companion to this patient to be able to give them that emotional support, the present, telling them that I am here, I am present, I'm not going anywhere. Even when you are sick as an individual, being the fact that you are healthy, don't you want to be catered for? You want to be catered for, you want to be pampered, you want to stay and you just want somebody to be there and make you feel like, yeah, at this moment in time, I have been caring for people and this is my time to be cared for. If your patient do not feel that love, if your patient do not feel that care, they will resent you. Is that understood? Next, you must be able to support and be compassionate, especially if your patient is having end of life care. If they are on palliative care, the care that you are giving to a normal patient, you should give that care times 3 to a palliative care patient. Okay? They should be treated with more tolerance, they should be treated with more love, they should be treated with more attention. Because for every more that comes from your side, you equally have more resentment from their side. because they are not looking at you. They are looking at the fact that their life is coming to an end. Is that understood? Okay. Promotion of independence. I always say that each nurse should understand the 14 fundamentals. Your 14 fundamentals are the instrument that is going to help you be a better nurse. We are not just nurses to be caring for patients. We are nurses to help patients each day gain independence. So if I started taking care of my patient out of surgery, the patient was first of all bedbound, and then the patient started using a wheelchair, and then the patient started using a walker, and then the patient started using crutches. I should be expecting that within another 1 month, my patient should be fully independent. Is that correct? So we should be taking care of the patient in trying to make them gain their independence. If you were bathing them today and they are still patients that are not bedridden, at least the next day they should be cleaning their buttocks while you put the water. Let them be able to do something. It makes everyone, you or I, we get our own fulfillment when we are able to do our things by ourselves. You don't want anybody to bathe you. You want to bathe yourself. You don't want anybody to be the one to remove pamper from your buttocks. You want to go to the toilet. And because they have this help, it is already standing between their way of gaining independence. So if you are caring for the patient, let the patient, if they can, gain independence at least one thing at a time. Is that okay? Even if they cannot get physical independence, they should have psychological independence. All right? If they cannot have psychological independence, they should have at least their disease should be progressing to giving them a life of themselves and not a life being borrowed by disease conditions. Is that okay? If the person was on insulin, say 5 times, yes, say the person could take insulin up to 5 times a day. They should be gaining independent by today they took 5, tomorrow they'll be taking 4, the next day they'll be taking 3. If they were chronic cigarette smokers and you are teaching them on lifestyle, today they were taking 30 sticks of cigarette, tomorrow they should be taking 28. You see, so the independence must not be physical independence. There is a whole lot of psychological and mental trauma that people are going through that they equally need independence from. Is that okay? All right. Next, we have environmental safety. You must always make sure the patient's bed is locked. You must always make sure that if the patient is using the walker is on the active hand of that patient. You must always make sure the bed rails are up. You must always make sure the bed is low, not high. You must always make sure that the floor is dry. You must always make sure that the electrical connections are safe. You must always make sure there is no knife or a fork close to the patient. You must always make sure that when you're going to the washroom, it is dry. You must always make sure that at every step in your practice, you have not given room for which a patient can harm themselves or you can harm yourself. Are we communicating? Okay. Next, we talk about assistive devices. When we talk about assistive devices here, we are talking about a walker, a wheelchair, crutches, or grab bars. These are assistive devices that can assist you and the patient to do an ambulation, to walk, or to do something on their own. When you want to use these assistive devices, first you must make sure the last service day and when the next service day is available for those that need to be serviced. Next, we must make sure that they are locked if we want to place a patient on the wheelchair. If I'm placing a patient on the wheelchair and the wheelchair is not locked, it will run away, right? And where will the patient go to? On the floor. what will happen to your back? How many times we are still taking care of a patient, we don't need number 2 patient. Are you understanding? So you must carry with safe techniques, and you must make sure that the wheelchair is stable and strong to be able to accommodate that patient, and it will not be running away because you kept it open. Next, when we are using a walker, you should be able to assess your patient at that moment that they are not drowsy, they are not having vertige, they are strong enough and conscious enough to be able to take few steps. Is that okay? Okay. Now we will be looking at documentation and report writing. Documentation is one of the most important aspects of your care, because you are going to be sending me daily reports every day. As much as you'll be doing your report, every blessed day you will send me a daily report, because I too will be doing my own report of that patient in the system. Is that okay? And with your documentation, we'll have your PMI forms. I gave you all your PMI forms, right? So with your PMI forms, you need to fill them, and you'll be taught on how to fill them and to fill them correctly. And when it comes to report, I will do reports when you are about to go for shadow. So I will have a class with you, and we will talk about the different types of reports, when your reports should come in, and what to do in case there is an incident, and what you should do in case there is a visit. When is admission report, how you have to make the report, and if it is a regular report, how you have to do the report. Is that okay? Okay. Report any change in the patient's condition to the supervisor or the healthcare team promoter. Next, key skills for a home care nurse. On your CV, when you want to talk about skills as a home care nurse, or the skills you are supposed to have as a home care nurse, number 1, you have to have a strong clinical judgment. Strong clinical judgment or strong clinical knowledge about the patient's disease condition. Because if you are taking care of a patient and you do not know what that patient is suffering from and how they should manage symptoms when the patient is having hypoglycemia, symptoms when it is hyperglycemia, symptoms of stroke, Habibi, that means that we will be taking our patients every day. They are almost dead. Are we together? Next, the next skill that the nurse should have to be able to work for a home setting, the nurse should have high problem-solving skills and critical thinking abilities. You must be able to think for yourself. I will not be there to tell you that do this, do this. When you are in the hospital and you're working with a supervisor, you can easily ask that the supervisor come and assess the scenario if you don't know what is going on. You can easily go call the doctor to come and assess, the doctor for that patient to come and assess. But you are at home. I am not there, the doctor is not there, the home case manager is not there. So you must be able to think and assess what you should do at every moment. Are we together? Next, excellent communicator and interpersonal skills. And that is why I will say there is no room for you when I want to talk, you start making there's no way. You have to be able to speak and coherent. Something that I can understand. Is that understood? In there, in your stimulation room, you will be talking between you and the assessors that will be present. I will not be there. And even if I'm there, I will not be able to say one word until you are done. Is that okay? So you must be able to speak and be audible. Next, we talk about organization and time management skill. Everything about health is time management. If you did it the wrong time, it is wrong. If you did it for the wrong reason, it is wrong. If you manage, somebody was about to die, you did not manage it, you want to come to manage when the person is dead, there will be no reason for it. So you must have a high organization and time management skill. Are we together? Next, cultural competence and adaptability. And that is why the first thing that we taught you in class is who the people of Qatar are. What is the culture? What do they believe in? When do they pray? What do you do when they are praying? What not to do? What do you do in the patient's home? What not to do? Because we are making sure that you are culturally competent enough to understand when you are breaching rules and regulations. Are we together? Next, working in diverse home environment, we have managing complex needs with limited resources. You don't have all the resources that you need. Next, addressing emotional stress for both patient, families, and yourself. If the day is stressful, I am expecting you to find something you find pleasure in to do. If your day was hectic, I am expecting that you know what to do at the end of that period. I am equally expecting you to be able to teach the family, to be able to teach the patient how to address their emotional stress. If you are not emotionally strong and competent and intelligent enough, you will not be able to teach your patient to be emotionally strong and intelligent enough. Is that understood? So I need you as a person to be okay, so that you can be able to give. You cannot give out of an empty cup. Is that okay? Navigating patients and family dynamic. You will go to some homes and you will meet so much love and care and compassion. Everybody is involved in the care of the patient. The family, the children, everybody comes in. And then you go to another patient, nobody's coming. Wherever you find yourself, that is where you'll be working. You mind your business and you take care of your patient. If you get where their family and every other person is coming around to sympathize and care for their family or their loved one, thank your God, join them and take care of that patient at the best maximum quality of care. If you get where there is no family member comes around, you become the family member of that patient. You should care for them, you should respect them, you should love them, and you should be their companion. Is that understood? Okay, this brings us to the end of this session. Do you have any question for me? Yes, my dear.
When you're taking care of the patient, sometimes the way some of the Catholic people are, they are very close. Some of the way you say the families are very close.
Close to the patient.
Yes, but now sometimes they try. Some of them they give you a. They don't know they're giving you a hard time, but they're giving you a hard time.
Yeah.
And you have tried severally to explain this. But maybe today one is coming, another different one is coming, and you can't just there, you know.
Yes, you cannot.
How are you going to, you want this patient to now, I want this patient to rest, but they're assuming that you don't want them to, how do you do that? Do you tell them to go away or?
You can't. Okay. Now, the person that has less family members coming to that patient will find more peace, sorry to say, than you having so many family members coming around. Okay. Now, why did I say so? When you have so many family members coming around, each and every person will come with their theory. Each and every person will come with their daughter and their son that is a doctor or a nurse. And they will tell you the medication that should be given, how should be given, whatever should be given to this. And yes, it is not easy. But it is very important that you start by knowing the completeness of your patient and their disease condition, so that you can tactically explain to somebody without necessarily opening a book, a diary, a phone, or anything, and explaining to them a good reason why they cannot intervene in the care. And before they send us, or before we send you to the patient came in through PNS, and PNS has given them an orientation. PNS has told them who the nurses are going to and what the nurses are meant for and their abilities and their capabilities. So yes, they might give you headache, but they will not particularly give you headache as compared if you were a private nurse. Are you understanding? If you were a private nurse, the family is the one telling you what to do, how to do, when to do it. But when you are a PNS nurse, they know you are being sent by the government. They will hand over the patient to you. However, they will still come. They will still come to tell you what to do, what not to do. Now, if you do not know what you are doing, you have to work according to what they want you to do. But if you know what you are doing, you will simply explain to them and educate them on the patient's conditions and the handover that was given to you in the hospital and the way forward. Because they know that the doctors will be coming to do rounds. They know that the nurse will be coming from the hospital to join you to do rounds. They know that PNS and us will all be coming to do rounds. So of course, they will not try to mess too much with your work. Is that understood? But you cannot send them away. You can actually just educate them, and if they will understand, they will understand. Is that okay? Any other question? Okay. If that is the end of the session, we will end for this course now, and we will start the next course within 15 minutes. Have your break.